much for your presentations as well. I'm Jennie Joseph. I'm a midwife. Been a midwife a long time. In my 42nd year of midwifery, I'm really proud about that. And yeah, I was only 10 when I started. So, let me get my presentation out. So I was born and raised in England, trained as a midwife in England, and I moved to the United States in 1989, and I've been in the States ever since. So nearly 33 years in America at this point. And that's been an experience in and of itself. When I'm talking about collaborative care, though, I think it's really important to recognize that midwifery and collaborative care goes together. It doesn't matter where you are, or how you're trained, or what you're doing, you need support. And so this is a really interesting panel to talk about collaborative care. Specifically, we're thinking about, oh yeah, the doctors. Oh yeah, the next level, the perinatology, etc. And today I want to talk about midwives and doulas. And I'm not suggesting that doulas are lower than or less than, any more than midwives are higher than or doctors are higher than. I'm talking about all of us who are fighting a fight to save lives. I have an organization in Orlando, Florida. It's 25 years old now. It's called Childbirth, and it's a non-profit organization, charity organization, and we work from a perspective of equitable care for everybody, every time, every person, every time. So really what I wanted to talk about is how do we collaborate as midwives in the United States and with doulas. Well, first of all, in case you don't know, midwifery is not normal in America. I'm just going to say it out loud.
There you go.
If anybody's wondering, that's what's going on. It used to be, obviously midwives deliver everybody, right? Midwives delivered America. Enslaved midwives delivered most of everybody, black and white, and continued on after slavery and into the early 20th century before obstetricians decided, oh, here's a good idea, and moved on from there. So where we are now is that midwifery is still fringe. Midwifery is considered outside of normal. We're making some traction, but we're not really getting to a point where we're effective in terms of addressing the maternal health issues of the United States, which are horrendous. In case you didn't know this, they are lagging in the developed world. The worst outcomes for the highest birth resource country in the entire world. Black women especially, and women of color, indigenous women, are dying at 3 to 4 times the rate of white women. But white women are dying too, and everybody who is suffering under that system is in a real dire straits, because we don't really seem to have an answer, and I'm not sure that we're looking for one. Let's talk about midwifery though, because wherever we are in the world, we know how to support our mamas, our babies, our families. And of course, we do that from a place of heart, we do that from a place of love. I have a QCO here, if you're interested, the International Childbirth Initiative. Step 10 is really relevant to what I'm speaking about today. If you want to download that, you have a copy of the ICI. I encourage you to look at that in 12 steps for a baby. So, I came up with a name because I like to make things up. Like I named my organization Common Sense Childbirth, but then I also came up with a model and I call it the JJ Way. My name is Jennie Joseph. See? And so, maternal-toxic zones is another phrase I came up with, because you wouldn't think you'd be finding so many maternal-toxic zones. You wouldn't think you'd have similar situations almost to what our colleague just spoke about in Papua, in Indonesia, also what we've heard about throughout this conference, of how people are suffering in these zones where it is not safe to have a pregnancy, have a child, have a postpartum experience. The toxicity surrounds them. And so we think about underdeveloped areas in America, we think about poor neighborhoods, disenfranchised neighborhoods, we think about poverty, classism, racism, sexism. But actually, maternal toxicity will show up anywhere, because it is from the people who are supposedly helping and supporting you that it shows up. That is why, if you know anything about Serena Williams' story and how she died in a hospital, nearly died, excuse me, in a hospital. She nearly died, God bless her, and she's pregnant again. But she was in a maternal toxic zone in the heart of the hospital with all the fame and money, good insurance, high-level providers. She nearly died because of maternal toxicity. Some qualitative work from the wonderful Professor Vidam and her team out of British Columbia, Canada, who talked about the fact that 1 in 6 women in the United States experienced mistreatment in the hospitals in the United States during childbirth. And of course, people of color more regularly than white people, but 1 in 6 experiencing some kind of harm, such mistreatment. And we run around the world and share about how respectful care is the answer, and we're here to show you how to do it. And yet, right here at home in the USA, refusing requests for help, violation of physical privacy, threatening to withhold treatment. These are the things that cause maternal-toxicity. These are the things that are rife. And so what we realized was it is not only the mother-baby family that are suffering, that are needing to be supported because they are traumatized, it's also the providers. Because how can you work in an environment where you know it's wrong? There's a moral injury that shows up. There is a sense of frustration, a sense of powerlessness when you are trying to provide care in these kinds of environments. So we realize that we also have to look at the workforce as a means to dissipating and mitigating maternal toxicity. The avenue, the pathway to that is through the workforce. The workforce needs to be equally feeling as safe and that they are protected, supported in order to do the work. Otherwise, we're not getting anywhere. So again, maternal toxicity, let me just kind of go through that again. I say it can be lethal. I think you'll agree. It certainly leads to an increase in morbidity and mortality. And it widens racial gaps. It widens class gaps. It impacts perinatal outcomes. And again, the impact on the provider is equally devastating because of this vicarious trauma, this moral injury, sense of helplessness, and overall lack of power. So what can we do? Well, actually, we go right back to respectful maternity care. How about that? Look, we know about this, right? I'm not going to belabor. There's no need. Right? World Health Organization has spoken. Safe motherhood, white ribbon. Everyone has spoken. We understand it. How do we get there? We need a safer system, not just for mother-baby family, but for all of us. This is the question I posed. Could it be possible that creating a culture and an environment that centers and supports all pregnant people could make the difference between their health, gestational age, birth weight, and breastfeeding rates in those women who are already at risk, who are already suffering in these systems in the USA, maybe even globally? The culture and the environment? So this J.J. Ray model, this thing that I made up, which is the midwifery model of care, the main premise is just every person wants a healthy baby. Every woman deserves one, right? It's that simple. And starting there gives us a place to jump off. So yeah, the answer to that question I posed is actually, yeah, you can get a big, fat, chunky baby at term out of anybody by doing some of these things. And this is a study that we started back in 2006 gathering our data. And I want you to realize, I don't know how to point this thing. Do I know how to point this thing? I don't know how to point this thing. Okay, so you're going to point this thing. This is a survey for African American and Black women. It is a study that we did of 100 women that were enrolled prospectively. That year, 21% of those women were having a preterm baby, but none in our study. The same demographic of people. Nobody had a low birth weight or a preterm baby in the African American group, and the Hispanic Latino women also 0. This is unprecedented because what were we doing? We were simply doing a midwifery model of care. So I want to make sure that we understand there's a relationship between the environment and the culture, the way you handle and relate to the clients in your care, that got us no low birth weight babies, no premature infants, and every woman thriving. Look at those statistics. Just happen to show us that actually this is possible. The cornerstones of this safe care shows up in these 4 tenets. Access to care, unimpeded. There's no reason why you can't conceive. There's no reason why you can't be supported. Connections, immediate, building trust, making sure that that respect is in place and that dignity is maintained. And once you get to that point, then you get the shared knowledge. You get to ask the question and have a true answer, because now there's an ability to exchange the knowledge rather than extract the knowledge or to point the finger and share knowledge in a negative way. And that leads to empowerment for everybody. This is another study we did in 2014. This was 2017. Same outcomes each time. 0 or low rates for preterm birth for Black women especially. I point that out because, again, 3 to 4 times as many Black women are dying in the United States across the board. Even while we've been here in this conference, another Black woman, a famous Black woman, these are the ones that get mentioned, that get put onto social media, died in the United States. Preeclampsia. She's dead. So these are the tenets again. So here is one of the doulas in our pilot program working with clients in the waiting room. We always make sure that there's access to staff member at every station along the way, the prenatal clinic. The doulas provide more prenatal and postpartum support than what you expect doulas to do. They don't just support during the labor. The main reason that we utilize doulas is because they're accessible, because they are congruent with the cultures that they're serving, their language, their matched language. They are readily available to provide wraparound support, and that is integral to removing trauma. Trauma-informed care doesn't have to be complicated. It's simply meeting people where they are. It's listening. It's zip it up. Just stop talking. Let her share. Let them tell you, and stop trying to insert yourself. But we find that we do it this way, we get those outcomes that I shared. So our community-based programs are centered in communities of need, but also making sure that we are connecting on a level that says we are working as a team. This is what's protected in maternal-toxic zones. So we make sure that we use doulas, educators, community health workers, medical assistants, even nurses who understand the local, that are from those areas, who can speak to the true barriers that are killing or trying to kill our mothers and babies. Quality care, culturally congruent care. Perinatal care meeting women where they are, physically, mentally, emotionally, and even financially. We remove that barrier. If you can't pay, if you don't have insurance, if you don't have means, never mind, come on anyway. What are we going to do? There's a baby in your belly. Hello. So we're going to keep going and make sure that we reach you where you are. And then the other piece is that the collaborations show up, because all of a sudden, folks want to join in with us and help us, because in turn it helps them. The physicians know about our practice. They send people to us because they know we will make sure they get seen, and we will in turn send them back when they need to be. We do not practice outside of our scope, but we do make sure that we are continually looking at our full tenets: access, connections, knowledge, and empowerment. These 4 lovely ladies, I'll go from left to right. So June on this end, she is still a doula. She's been with me about 10 years at this point. She's everybody's grandma. She's from around the way, and we all love her. Megan, who's next to her, Megan is now a nurse practitioner, but started with me as a birth assistant and became a doula and moved into nursing. She's heading to midwifery. Katrina with the pink stethoscope, she's been with me nearly 20 years, and she is now the division leader for our health services division. So she's grown into that from just doing work in this model. And Alexis is also a medical assistant. She's not with me right now, but she's pursuing a registered nurse training, and she started with us 10 years ago. So this is how it works for us. We know that using and supporting doulas to support us as midwives is expanding the perinatal workforce. It's opening up the opportunity for clients and patients to be seen in a culturally safe, culturally congruent way that empowers them to their full health. Our cesarean rates for our hospital-bound mothers, which is the majority of mothers in our practice, 17%. In the United States, it's a big deal, where it hovers around 30%, 35%. 1 in 3 women are getting cut. Our mothers go into the hospital without support sometimes, without a midwife or a doula to support them, and yet they prevail. We know what we need. We need access to safe quality maternity care. We need appropriate level providers, and we need to collaborate with those providers up and down, both ways. We need access to anywhere this mother or this birthing person says they want to be. Home, birth center, clinic, hospital, they choose. And the providers need access to understanding. This is an inbuilt historical structure that prevents us from working together, that stops us and holds us back because we get ourselves all caught up. We just need to get over ourselves and get on with it. We're here for each other. We've understood this from time immemorial. Nothing new here. Breaking down these systems of structural harms and disconnect and broken care, we do that through our relationships, through our love and our trust for each other, and in turn our families benefit from that. Cultural humility training never hurts. Reaching in and working collaboratively, making sure everybody's on the same page. And we need our students to be able to understand this pathway. All of our midwifery students, and we do have a midwifery school in the United States, training community midwives. Doula is your access point. That is your prerequisite. Do that first before you even come talk to me.
Yes.
So this is what you get when you do this kind of model. These lovely, healthy mamas, these are postpartum group mamas, see the babies who are all chunky, healthy, doing well, mamas are breastfeeding, mamas are smiling. It's possible. So I just want to share that little story.